Whiplash, always an emotive topic, mainly because it's associated with such controversy and litigation. But today I thought we'd share with you some of the clinical aspects involved with whiplash. As the term describes, it's a very general kind of description about how an injury occurs, usually trying to describe this whipping mechanism of the head relative to the body if there's some sort of an impact. But of course, there are a lot of other variables in terms of the direction of impact, whether people see the impact coming, the speed, whether they're stationary or moving. So there are a lot of other variables involved that all get lumped under this general description of whiplash. But it's a term that's just used to describe how the injury occurs. It tells us absolutely nothing about what's causing the pain. And that's really where, from a clinician's point of view, we need to delve in and try to identify what structures are painful, how much damage has been done to them, and what the time course for resolution is, and what sort of interventions are required to try to improve situations. There are people on the severe end of the scale who are unfortunately left with intractable pain as a result of a whiplash mechanism. So there is a proportion of people, and then there's a whole sort of cluster of people with different levels of symptoms, different types of disabilities associated with it, and a different duration of recovery. The general international classification of whiplash is to divide them into 6 categories from grades 1 to 6, which are at the simple end of the scale, just low-grade muscle strains, which are no different to a slip or a fall, which cause a little bit of muscle strain, and that might be a few weeks of very minimal discomfort and soreness, and they're often cases that just don't end up going to a clinician because they don't cause much dysfunction. So they are at the very simple end of the scale. And then as the degree of damage increases, then obviously the degree of pain and discomfort increases. So people will usually consult the GP, maybe get some anti-inflammatories, some antispasmodic medications, and nowadays you very rarely see a soft collar prescribed for whiplash. Back 30 years ago when I started, that was quite common, and people were left in soft collars for 6 months to a year or whatever, and that was very detrimental. So you rarely see a soft collar handed out now when patients present with whiplash. It's almost become routine to be assessed in casualty if it's a motor vehicle accident, and that's because a very, very small proportion of patients with a severe whiplash can have a fracture in the spine. So usually an X-ray is undertaken just as a precautionary measure, but almost 99% of people don't show bony injury when an X-ray is done after a whiplash mechanism. So that's, as I say, a precautionary measure to exclude serious bone damage. Often, if the symptoms persist for a matter of number of months, people may well say, well, let's get an MRI scan, which will show more detail. And in the vast majority of cases, an MRI scan doesn't add very much to the clinical diagnosis. Excuse me. So it's just what you have is a situation where there isn't gross destruction of tissues. It's just simply that they've become irritated and sore. So that often is a source of frustration, because usually if people are quite painful, they expect the scans to show that there's destructive damage, and then a small proportion of patients will have perhaps a disc protrusion as a consequence. But by and large, the scans don't show a huge amount of change. And as I say, that can then lead to frustration because people feel that there isn't a structural explanation for their pain. And if there's litigation involved, particularly if it was an accident where you weren't at fault, then, you know, depending on the medical view, one side will claim, well, the scans are normal, there can't be much pain, and the other side will say, well, look, this person is attending for treatment and has had medication and scans and whatever, and ongoing physiotherapy, so they must be having something treated if they're having a problem. So that's where a lot of the debate centers around. From a clinical point of view, the real key is trying to identify what structures are aggravated, the degree of damage, if it's possible to assess that, and then what types of treatments are required. So in general, will be moved from the simple end of the scale to a low grade muscle strain. Then the next tissues involved can be the ligaments around the neck joints. So if the ligaments can be strained or badly strained or torn in some situations, the joints can become irritated. In the more severe cases, you may get nerve irritation, but not because the nerve is compressed. Sometimes just by suddenly stretching a nerve, as what happens with the mechanism of injury, that can be enough to sensitize the nerve. So that's sometimes missed clinically, in that people assume that if a nerve is sore that it has to be compressed, but compression is only one way in which the nerve gets sore. If the nerve is stretched and pulled around, suddenly that can irritate it and make it sensitive too. So that can be an important factor perpetuating nerve soreness. And sometimes if the nerves get very sensitive, strong nerve-related pain medications need to be used to try to stabilize that. If symptoms are very severe, very often there'll be acute muscle spasm, and that will tend to lock the neck up. And if that subsides over a number of weeks or months, then very often you're left with other muscles around the upper back and neck and shoulder blades that aren't really functioning very well at all. So treatment needs to try to improve the postural function of the muscles in the back of the neck and the shoulders. And some patients who have long-term complications, their muscle control around the neck gets really inhibited, and they end up with a lot of tension in the big muscles, the trapezius muscles at the back of the neck and head, because some of the other deeper muscles get damaged and switched off, and they have to be specifically rehabilitated to improve their function. And heaviness in the head is one of the common things that people tell you, that they find that the head just feels too heavy. So that's a good, important clue from a clinician's point of view. In complex cases, if there's been significant joint irritation, sometimes they require an injection, what's called a facet joint block. So the pain specialists usually do that in theatre, which is an image-guided technique. So using appropriate visualization, they can inject a steroid into the joint to try to calm it down. But usually in that situation, patients have progressed from having very diffuse pain all over the neck and upper back and maybe headaches, and it's now resolved into a more specific area, which then is a specific target that you can use for an injection. If you still have very generalized pain, then it's not really an appropriate kind of a condition for a targeted injection, because it's too diffuse, and that usually requires other kinds of medications. Sometimes medications that people don't like because it can make them feel a bit dozy and a bit out of it. So really, when you have a situation where people are in pain but the scans don't show abnormalities, systematic examination is usually very clear-cut in terms of identifying if structures are sore, whether that's muscles, ligaments, joints, or nerves. And sometimes that just doesn't get done in a routine sort of orthopedic examination. People look at the scans, they look at general range of movement, which often, when the acute pain has subsided, range of movement isn't restricted. But it's only when you drill down and look at physical examination of specific joints and muscles and assess how the muscle control is and the nerve sensitivity that you can determine whether there is still ongoing underlying sensitivity. And that's important, because that helps to sift out people who are just perpetuating a claim, as opposed to having genuine physical symptoms. There's an awful lot of detail one could get into in whiplash, but I just thought to start this series, we just give an overview, and then we'll delve in a little bit later in some subsequent videos. Hope you found that helpful. I'll see you again in another video. Bye for now.